Good morning, colleagues. Welcome to this Thursday morning webinar. Colleagues, these webinars are brought to you by the Vaccine Advocacy Resource Group and the African Alliance in a partnership with APHA, the Treatment Action Campaign, and the Community Constituency COVID-19 Front. The work of the African Alliance is supported by the South African Medical Research Council and the Department of Science and Innovation. Colleagues, today we're all about testing and laboratory services within the COVID-19 pandemic. We're joined by Professor Koleka Mlisana, who is the Executive Manager of Academic Affairs, Research and Quality Assurance at the National Health Laboratory Service. She's been in that role since July 2018. Prior to this, she was the head of department at the Medical Microbiology at UKZN, IALCH, and also served as a member of the NHLS Board. She has been previously active as an HIV and AIDS researcher for over a decade, focusing on HIV prevention and pathogenesis, working at the Center for the AIDS Program of Research in South Africa, CAPRISA. She has undertaken seminal research, which has revealed how the body responds during acute HIV infection. Her current research interests include TB diagnostics, antimicrobial resistance, as well as sexually transmitted infections, and has co-authored more than 130 peer-reviewed journal articles. She continues to supervise postgraduate students, as well as examining postgraduate theses from various academic institutions. Amongst other national commitments, colleagues, Professor Mlisana currently chairs the Pathology Laboratory Committee on the recently established Ministerial Advisory Committee for COVID-19. She serves as a member of the Ministerial Advisory Committee on Antimicrobial Resistance and is a member of the Board of Trustees for the South African National AIDS Council. She has nurtured and mentored many young scientists. Her passion is to groom the next generation of leaders and scientists to be well-rounded individuals academically, socially, and spiritually. Colleagues, again, welcome. Prof, thank you so much for joining us. It's always a pleasure to hear you speak, and we look forward to an engaging 1 hour of learning more about your work and the general testing and laboratory response to COVID-19. So over to you and welcome again.
Thank you very much, Tian, and thank you to the organizers for inviting me. And some of those know how much they have twisted my arm to get me to do this. But anyway, they are forgiven. All right, thanks for inviting me, and just for me to share briefly on issues pertaining to testing. What I'm going to do is I'm going to share my screen so that we can I can talk to what you can actually all see what I'm talking about. Is that showing clearly?
Thank you. Yes, I can see the screen. I'm sure others can as well.
Yeah, let's just make it bigger.
Colleagues, while Prof. Mlisana is setting up, just a reminder, please use the chat function to insert any questions or comments as we go through the discussion, and let's keep it as lively and engaging as possible. Yeah. Back to you, Prof.
Is that fine? Can you see it clearly?
Yes, we can.
Okay, thank you. So as already mentioned, I'm a microbiologist by training, and currently I am with NHLS in the central, office, corporate office, and I look after academic affairs, research, and quality assurance. So with the COVID pandemic, I thought where I will start is then to just look at what we have been doing as the MEC, so Ministerial Advisory Committee. And as already mentioned, I actually chair the subcommittee that looks at pathology and laboratory issues. So firstly, I think for me, being appointed, into the MEC was obviously an honor, which one, was humbled about. And secondly, it gave one an opportunity to make a contribution, in managing the pandemic. And especially when then we're looking at the laboratory issues and the subcommittee, when my peers and colleagues actually thought, I was able to lead them. And what have we been doing apart from, being involved in all other conversations, throughout MEC, but specifically our subgroup, has been was tasked with looking at advisories to the health minister and the health department on issues pertaining to laboratory testing, which means issues relating to diagnostics. So what we have been doing has been to actually look at, what is it that needs to be done when we talk about, testing for COVID. What samples should be used for, for testing? For instance, when we started, we're talking about both a nasopharyngeal and an oropharyngeal swab that you needed to take both and put them in one, in one tube and send it through. So we had to look at that. Is that the ideal? Is it, practical? And when we realized, when there was enough evidence to show that actually just one sample was fine, so we actually wrote that advisory. And then there were also other samples that came in, could we, for instance, use saliva for, as a sample, as opposed to nasopharyngeal swab. So we did actually write an advisory to the department around that, and also even which test to use. Remember, there's always, you are either looking for the virus or you're looking for the immune response. And insofar as looking for the virus, for instance, right now we're using the PCR test, and we had to say yes, for now, that is the only test that should be used in the country, because the immune responses, serological tests were not available at that point in time, and also the value thereof, it was unclear, as it still is right now. So we had to give advices around that. And then even the testing, how do we then test, what are some of the innovative ways that we could use, and cost-effective ways we could use in testing. So we came up with the pooling algorithm. This was only when the positivity rates were still very low. And we also have looked at the role of serological tests, and some of those advisories are coming out. And then when there was a challenge with testing, we needed to go back to the drawing board, and we looked at how can we then reprioritize and identify when, testing should be prioritized, as opposed to when we're doing community screening and mass testing. So those are some of the activities we have been involved in as the lab subcommittee. But otherwise, as I have already said, then we get involved in other discussions. And the good thing is that the minister now and again joins these meetings, and we can actually get either a response from him, or if he has got questions, he then can actually ask those questions directly, when he joins the meetings. And then just moving then to the laboratory issues around COVID. I think the critical thing is that we all understand that really lab testing is the cornerstone, in managing the pandemic. And this was, clearly, communicated by Professor Abdul Karim when we started, where, the whole idea is we need to identify people who are infected, so that then those individuals, we can trace their contacts, and we then are able to quarantine or isolate depending on whether people are positive or not. So really we have realized that when it comes to laboratory testing, it really is priority, both for clinical management as well as controlling the outbreak. And so what has really been happening is that, as we all know, in South Africa, we've got two, health is basically stratified into two sections. There's the private sector and there's the public sector. So even with COVID testing, we know that we've got private sector laboratories as well as public sector laboratories. And basically NHLS forms the public, because NHLS is the public laboratory that services all public healthcare facilities. So we have been looking at testing from both. And right now, as we speak, I think this was probably last week, and I don't think there's any new lab that has joined. Remember, NHLS has got a national platform, but not all the labs, not all NHLS labs are actually doing COVID testing at the moment. There are 27 labs. When we started, it was just the academic labs, because that is where the virology academics sit in. So we started with that, but as we realized that actually there was a need to increase capacity, then, the testing was decentralized, and we now have got 27 NHLS labs that actually do testing. And then as far as the private pathology labs, we know we've got the big, probably 3-4 main labs in the country, but there has actually been a range of other private laboratories that have come up and on board and have said, yes, we've got the resources, and we therefore will contribute to COVID testing. So we have got about 25 pathology and private pathology labs. that are performing testing. And then what then happens is that all these labs, their data gets then loaded onto the NICD, National Institute for Communicable Diseases. So from NHLS, every NHLS lab that does testing, the data daily gets loaded onto, so downloaded onto the NICD data warehouse, and the same applies with the private sector. So the testing numbers that everybody sees every day are therefore, they combine both the private and the public sector. And we do this every morning. I mean, like now, I'm supposed to submit, the testing numbers by 12, by 2 o'clock every day, just so that, there is the daily reporting of testing. And what we look at is the number of new tests for that day, number of positives as per province, how, from NHLS, what labs were contributed, and from the private sector, which labs contributed. So that's what we do. And really thus far, what are some of the highlights? Actually, this morning, we're sitting at about 3.48 million tests that have been performed. I think when I prepared this slide, it was a week ago. We're sitting at 3.48 right now. And the highest numbers, that we tested were in week 27, which I'm showing here. Week 27 and 28, where actually in just 1 week, we had done almost 270, thousand tests in 1 week. And that was the highest that we really did as a country. And remember, this is both private and the public sector. And what are some of the issues? So I think for me, when we had the lockdown, what it did, it allowed us time to assess the testing capacity in the country. As a result, when NHLS specifically looked at the available resources, we're able to identify what we had and what we needed to have to ramp up, for the increased testing that was expected. As a result, the testing sites were increased and the platforms of testing were also, increased. And even with the private labs, even though we have got just a few private labs, there were a lot more that came on board to actually assist with testing. And what also happened was that in increasing the capacity, we also then had academic research labs come on board. For instance, at UCT and Stellenbosch, at Verts, at UKZN, in Walter Sisulu, in Sefako Makhato. So there are actually labs that have come on board, and they are able to do testing. Okay, so what then? Somebody tells me the slides are not moving. Is that correct?
They seem to have frozen. Prof, it's gone back to slide 1. Oh,
and I'm on slide 4, which is halfway through. I'm not sure how to do that, and it's moving on my side.
They were moving initially, unless you unshare and we can share again. That might refresh it.
Sorry about that.
No worries.
Okay, I must find the correct presentation. Is that showing now?
Yes, we can see a slide that is entitled Gaps, Challenges, and Proposed Solutions.
Excellent. Yeah, that's actually where I was getting to, because, so that was really what we did insofar as testing is concerned. And then I thought I'll just have a look at, what are some of the challenges that we have seen insofar as testing is concerned. First, initially when we started, we realized that actually there was limited access to both reagents and other consumables. Remember, this is a global pandemic. And so when we're talking about PCR, extraction, RNA or DNA extraction or PCR amplification, and you find that it's not just us as the country that's looking for that, but it's the whole world. So we really had a serious challenge in accessing, the reagents. And secondly, especially for extraction, we realized that actually within the country, this is now both private and the public sector, we did not have automated platforms. And with the huge numbers of samples that were coming in, this became a serious bottleneck. As a result, if you remember with the testing strategy, initially there was a specific group that would be tested because they had symptoms and they would come in or they were contacts. But then we moved to a community screening and testing phase. As a result, there were loads and loads of tests that came in. And because we did not have adequate access to reagents. We did not have automated platforms. The labs ended up with a huge backlog, especially in the NHLS, because the community screening and testing was done in the public sector. And obviously, when then we had this huge challenge of backlogs, and which meant prolonged turnaround times, it was truly a challenge. So what did we do? What are some of the of the solutions? For access to reagents, we had to diversify the platforms that we're using so that we can increase use of open PCR platforms, which then allowed us to order more than just one specific extraction kit or one specific amplification kit. So diversification actually helped there. And with the extraction, we had to explore other methods like heat inactivation and lysis, so that then we could proceed with amplification. And then with the backlogs and community screening, as you are aware, then we had to revise the testing strategy, and we introduced prioritizing specific populations for testing. The other challenge that we had is, as everybody is aware, was that we're seeing this increased number of lab staff that was requiring quarantine, and also managing these many labs, like I was saying, that were coming in and wanting to test. So we had to actually develop systems and processes. How do we evaluate, and how do we actually audit some of these labs to see whether they're able to do what they claim that they want to do? So all of these have continued, and I think we are still in the process where we identify a challenge and we find a way of how to resolve that. And so where we are right now, we then, let me just move this. Okay, so what are some of the lessons that we have learned? I think for me, it really has been that it is critical to plan in advance, well in advance. And I think the initial, lockdown that the country, embarked on very earlier on, it really gave, for us within the testing arena, time to assess what we have, what we don't have, and put processes and systems in place. So, where, planning well in advance was important. And also what I see, this whole, pandemic having done is that it has actually brought the private and the public sector very, into close collaborations. In fact, there were times where we would have meetings with both the NHLS and with the private labs, and we had to look to see what are some of the methods we could use, because we don't have automated platforms. And so there was a lot of exchange of ideas and learning from one another. And also, key communication always is important, because when the community screening and testing came in, there was a lot of confusion and people were not doing what they were supposed to do. There were people who were doing mass testing, which really was not the intention of CST. So we needed to communicate, quite often with the Department of Health, and also as the labs, when there were problems, we needed to highlight those early and say, hey guys, we are not managing, the volumes are too much for what we can handle, and therefore the turnaround times are going to be delayed. So it was important for those communications to occur. And also, as is shown now, to make sure that there's constant review of implemented policies and guidelines. And obviously, this is directed by the pandemic. And in fact, right now, we're sitting with a situation where we changed the testing strategy to prioritize testing. And what happened? There's been this decline. In the last 2 weeks, the numbers of testing have been very, very low, have actually reduced significantly. And so we are now going back to the drawing board and saying, this is probably not right, because whilst we're seeing everything coming down right now, the fact that we're seeing fewer cases, we don't know, and we think it probably has got to do with the fact that the testing numbers are low. But what is helping for us to view, to actually have an overview of the pandemic, is when we not just look at, reduced number of cases we're seeing in the last 2 weeks or so, but we have also looked at hospital admissions, because then seeing that we reduce testing, what is happening, you would expect then that there'll be more hospitalizations. And that's why we feel, because now we're seeing lower hospitalized patients, then it means we probably are over the peak to an extent, but it's not time for us to say, okay, fine, everything is done. But we are now going back to say, can we increase the testing now? What are some of the populations within the country that should be tested? That is why the minister, for instance, talked about making sure that all natural deaths, they must be tested if one had not been tested before. And also we're looking at strengthening and enhancing contact tracing so that we can test close contacts, because we feel some provinces did, when there was a challenge, initially they sort of did not manage contact tracing as they should. And so right now we're currently reviewing the testing policy, and I'm sure we'll come up with something very soon. So I think that's my last slide. Why is it still saying that's number 7? But anyway, so the way forward, we need to review the current testing strategy, as I've said. And also because we're anticipating that there might be a second, a surge. So how will we manage that surge into the future, and making sure that we've got everything in place for that? And obviously there's been a challenge, with improving our data. And so we're looking at that. But also it becomes important for those labs that are now wanting to come on board. We've realized that there are actually National Department of Health regulations, which some of the labs may not have complied with, and we're now cleaning that up. So actually, really, that's where we are. And hopefully when the surge comes, next, we will be ready. Let me end there. Thank you.
Great. Thanks so much, Prof. That was really insightful talk. I just want to touch on some of the pre-submitted questions, and then we can go through some of the questions in the chat. Perhaps we can do 3 at a time, if that's okay with you.
Okay.
Perfect. So the first one, could you speak a bit more to your intention of engaging civil society in the revision of the revised strategy, and if civil society has been engaged, how has that happened? Then a common thread in the chat box is really speaking about how did we get to a point where tests became so expensive to access, and there's a quote of 1,400 rands where it went up to. And then I think a third question we can take is, can you speak to a bit more about the impact that clinical trials are having on the testing resources? Is there any relationship between the research and the NHLS services? Thank you, Vet and Tando, and Yumna, for those questions. So the first one around civil society engagement with the testing process. Why is testing so expensive? Because I guess communities are not seeing the partnerships that you speak about filter down to the ground. And secondly, the relationship between NHLS and testing and research.
Okay. All right, thanks for those. And I think those are actually important questions. So I must say, actually, now that you're raising this question of civil society engagement, when it comes to testing, from the MEC, we really have not been doing that. I must be honest. Really everything has been very technical. And what then usually happens is that we would then put together an advisory, and then that advisory goes to the Department of Health. And I suppose then it's at that level where then the implementers of the advisories would engage with everybody. That probably is, is an area which, we need to look at and see how we then can, because remember, how the MEC was formed is that we were identified by the minister. And so it's whoever is there, and you find that it really just is purely technical, individuals. And so there really has not been much engagement with civil society, and we would need to then going forward see and explore if there are areas where civil society, there are ways and means of making sure that there's engagement at that level. Why are tests expensive? There has been a lot of discussions to and fro about this. Remember, this would be now in the private sector, because as far as the NHLS is concerned, we actually have proposed, a cost to government, which they have agreed upon. And there has been discussions where actually the question was, shouldn't government be, directing the pricing in the private sector? But if if my memory serves me well, I think a lot of private labs have actually reduced their testing, and the 1,000, you know, the cost of more than 1,000 rand, it was initially, but then when discussions were going ahead with the, you know, the private sector had to come up with one price, and I know that it definitely is not more than 1,000 rand. I think it's around 600 or so. So the tests have come down. And so it just really depends. And if they have not, you know, in certain private labs, one would need to find labs that are cheaper, because really right now there is no need for tests to be this expensive. And what about clinical trials? Really, clinical trials do not affect the testing within NHLS, because what often happens is that, you know, whenever there's a clinical trial, the researchers usually identify a lab that does testing, and I don't think we are actually doing such high numbers that, you know, the clinical trials would have a negative impact on ability or capacity to test. So I'm not really worried, because right now, I mean, as you can see, you know, we're doing such low numbers anyway, so there's more than enough capacity, and that would be able to take care of whatever labs, private labs or other labs that are doing, you know, testing for the clinical trials. Over.
Great, thank you for that, Prof. So a series of questions from Sinazo, Pumzile, Yvette, and Yumna. The first one is, can you give us clarity? Do you have any additional clarity on reinfection? Are you noticing any trends? That question from Sinazo. The second one, I guess, really follows a thread throughout our discussions, is at what stage, or do you think that stage is now, can we as activists and community organizations stand up and, as they say, speak with our chest and say we are confident in these numbers? At what point do we get to say we are 100% confident in these testing numbers? And then the next question is, you spoke about 27 active laboratories. Yumna is asking you to speak a bit more about laboratory capacity, and is that peak capacity, or are the 27 you spoke about just a certain percentage? And the last question I think we can take for this round is from Pumzile, that speaks to the coordination of laboratories across the country, both public and private. Is that coordination happening, and what are you seeing from that coordination of laboratory services and testing services across the country? Okay.
So reinfection, I smiled when you raised reinfection, because we're currently actually drafting an advisory on reinfection. So, and that's why I didn't, you know, want to talk about it. And we know that people are now starting to ask those questions. And really, if one looks at the literature, there really has not been any confirmed evidence that's confirmed of reinfection. So what we are busy doing now is to look at the, you know, at the literature globally. What is happening? What has been seen is situations where you find somebody who was positive, you know, had the infection, had everything else, and they test negative one or two times. I think there are 3 or 4, you know, papers that actually were publishing those case reports. And then after being negative once or twice, they then became positive again. And the question is, what is actually happening there? And really, when you follow those case reports, these are individuals. Remember, we are using PCR testing, which is we're picking up genetic material. So what happens is, and we know this phenomenon for any other PCR test, in that the genetic material does not tell you whether the virus is replicating or not. It is just there. If it's RNA, you'll pick up RNA. If it's a DNA virus, you'll pick up DNA. So what we know is that when people did comparative tests to look at the PCR versus viable, you know, virus, where they grew and cultured the virus, we have not seen any viable virus beyond 10 days of infection. And so whatever positive PCR beyond that, we believe it is degenerative, you know, genetic material. Now, depending on when you do the test or when you don't, sometimes you might pick it and you might miss it, or sometimes, you know, it might appear after a few days when it was negative. And we think really that's just what it is. So we are still yet to explore and see and follow cases to see whether reinfections are occurring. But for now, there has been no, you know, published case of a clear-cut reinfection. Confidence in testing numbers. I'm not sure where that question is coming from, because as I have explained, really, the numbers that we're reporting on daily, those are the numbers that we're testing in the country, because every lab that does testing, they're supposed to make sure that their numbers get reported to NICD if they're in the private sector. And insofar as the public sector is concerned, so NHLS has got, a footprint across the country, but we use one single laboratory information system. So all the data goes onto our LIS, and that data every day, it gets, downloaded, as I said, onto NICD. So NICD combines both the private sector as well as the public sector data. And so the numbers that we're reporting, those are the numbers that are getting tested in the country. The only issue would be if there are labs that are out there that we don't know of, which should not be happening, and they are not reporting their numbers. But otherwise, every other lab that is actually operating within the framework of the country, they should be, submitting their numbers, and we get that every day. So I have a lot of confidence in the numbers that we have and the numbers that we are reporting on, especially for testing, because I actually present those numbers myself, okay? And then the capacity, so when I was talking about 27 and 25 labs, so it's 25, whatever, one in the public sector and in the private sector. So when we then look at the capacity to do the testing, we actually have just done that exercise as NHLS. So we looked at the platforms that we have, we looked at the available reagents that we have currently, and we have actually, we're now confident that NHLS would be able to go up to as high as 28,000 samples per day. We can test that. And if you're looking at the private sector capacity, it's another 25 to 30,000 as well. So really, when you look at this as a country, and we're basing this on the numbers that we have seen before and the capacities that the labs have shown before, we can comfortably do 50,000 tests. Now, this is provided there's regular supply of reagents, and human resources are available to do that, because we're talking 24-hour labs, so really, and this is across the platform, sort of across the nation, in that in every province, there are testing labs. So there's really a good footprint across both private and the public sector. I think I've addressed all the questions that you raised, Jan.
Great, thank you for that. And then just a note to colleagues on the call as well, as per usual, any questions we don't get to during this 1 hour, we'll liaise with Prof and her team to ensure that all of your questions are answered. So Prof, for the next round of questions, Yumna is asking you to speak a bit more. What are your thoughts on mass testing? The second question is, now that the economy is open, and Yvette is asking this, and I guess it links to what Yumna is asking as well. So now that the economy is open, what does that mean for testing? Then a third question from Ntando is saying there was talk about a social behavioral group team being set up. Can you maybe give us an update in terms of how far that advisory group is? Has it been set up? Have terms of reference been established, etc.?
Okay, thanks. Mass testing. You see, if we had the capacity and the resources, as we had said originally, I mean, as the outbreak started within the country, that really the Achilles is to really make sure that we test as many people as possible. So that would be the ideal. But we probably are now beyond that, because, when we tried to do it, we failed because of some of the reasons that I have already highlighted. And so where we are right now, I don't think mass testing would make a big difference unless we have got different diagnostic methods. Because remember, right now, all we have so far, it is still PCR, detection. But now there are, for instance, there's serological tests that have just been approved by SAPRA, and they are also looking at approving antigen detection tests. And some of these, they're actually rapid tests. So really, mass testing would be ideal if we have a rapid, rapid test. And the question then would be, if we want to look at mass testing, what are we trying to do? There can be mass testing looking at prevalence, in which case then populations that have had the infections, and we are looking to see where, how much infection is there, and that we could use serological tests, antibody detection tests, and as I've said, some of these are rapid, so that would actually work very well. Or if you want to look at people who are infected, then the antigen test would come in. We don't have one test that's approved as yet, for antigen testing, but there should be one, soon. So when that test becomes available, we can then explore and say, well, maybe we could increase the net of the people that we're testing. So right now, for as long as we're still using PCR, there's going to be limitations, and mass testing is not going to be ideal. Open economy, yes, that's why we're talking and are concerned of a second surge, because as people flood to work, and it was good to hear the president stress the fact that people need to continue with social distancing, wearing of masks and washing of hands, because that is really what is going to contain, another surge. But, you and I, people forget about that. We don't know what's going to happen as people get back to work, whether they're going to keep the distance or not. And so therefore, that's why in my last slide, I was saying we need to gear ourselves up for a situation where, with the opening of economy, more relaxed, rules around, movement, then we might end up with another surge. And that's what we're trying to do, and make sure that we are prepared for that. The social behavioral advisory, yes, there is, Ntando. It actually, it has been established because in one of our advisory committee meetings, we shared it with them and we were introduced to them. So that advisory committee is up and running, but I must say I don't know where they are, what's actually happening in that, and so that's something that you could explore and see who is in that advisory. I know there were lots of civil society, members, and even members of the clergy, and different, members that are part of that committee. But like I say, it has already been established.
Thanks for that, Prof. Yes, I think I saw both Comrade Steve Letsike and Mabelane Mfundisi on that list, along with some faith-based movements. So thank you for that. And I think you've also touched on Yvette's next question was, are we ready for the second wave? And the way I'm reading you is that you're feeling pretty confident that we've done as much as we can for that second wave.
Yes, and I think we're better prepared now. And also, when we're taking stock within NHLS, even the reagents, we've got, enough in stock at the moment. So, we're trusting that we'll be able to manage this.
Yeah, touch wood. Next question is, how is contact tracing as a mechanism effective? So could you speak to the efficacy of contact tracing as a mechanism? Then could you give us your, I'd love to say, final and full stop ruling on the temperature machine? Is this
a question?
So the second question, Prof, is the temperature machine. The third question is, tell us about resourcing for the NHLS. Where do you get your funding from? Has Solidarity come to the party? Is Solidarity welcome to the party with their billions? Have they already been to the party? So could you touch on the temperature machine, contact tracing efficacy, and Solidarity and your funding?
Okay. Can I skip the temperature question? Anyway. All right.
Unfortunately not, Prof.
Yeah, I guess I don't have a choice. Contact tracing. So remember, really, when because of the nature of transmission of the virus, it really, as we all know now, droplet spread, and there's also concern about aerosol as well. So the whole idea is that people who are in close contact, they are the ones that are highly at risk for transmission. So if we were to do contact tracing effectively, you know, in a situation where I develop symptoms. Now, the challenge, and that is why it makes contact tracing critical, is that we know that the virus, you know, you shared the virus if you are infected as early as day 1 or day 2 of exposure. So it is very early on. So even whilst you are still asymptomatic, because what happens, you get the subclinical, you know, phase, and then you come up with symptoms. So you find that you can get infected on day 1 and only manifest with symptoms on day 2 or 3. But even at day 2, you would have actually been, you know, shedding the virus, and therefore you are a risk to those that are around you. And obviously, depending on the severity of the disease, is also related to the virus. I mean, to the viral load, you know, during infection. So that's why it becomes, and the other danger as well is that, you know, data is showing that even people who don't manifest with symptoms, the asymptomatics, they can still, you know, transmit the virus. So that's why then contact tracing becomes important, because if I present with symptoms and assume I'm at day 3 or 4 of infections, then I need to be able to identify people that have been closely to me for the past 2 days, and then everybody else around that time. And if we can do that effectively, because then we'll be able to identify, go in to those contacts and test them. And you'll find that when contact tracing is actually done efficiently, you are able to pick up a lot of infections. And we saw this happening in the Western Cape, in that the Western Cape, for some reason, they had a very good system in that when they were testing whoever, they end up with a very high positivity rates, because it means their testing was targeted amongst those who were at high risk. So it really can be a very effective, you know, way of identifying those that are infected. Temperature measuring. Everybody is doing this. Yeah, I wish I could say, you know, I should not be quoted on this one. This morning, when I walked through, you know, at our gate, my temperature was 33 point something, and I was like, oh my goodness, I probably in the mortuary dead, you know, with such a low temperature. So I mean, there are pros and cons to this temperature testing, because remember, you know, especially, you know, some of the instruments that are being used, they really just, if I've been sitting in my car and my car is always, you know, my aircon is always on, whether winter or summer. So, I mean, the surface of my skin will be cold. And so it really also depends on how the testing is done, and it can't just be monitoring the temperature alone. There's got to be other things that you look at. And that's why when we're talking opening the economy, it can't just be that, you know, that screening of the temperature, but what about the other symptoms? There's got to be like a daily screening, you know, list that everybody goes through, and not just the temperature. Let me leave that. And then the resources for NHLS, I must say actually that, yes, thanks for bringing that in, the Solidarity Fund. NHLS, obviously, you know, our revenue, we get it from government by, you know, through the test that we're doing. And so what happened with when COVID started, yes, we were given a donation by the Solidarity Fund, which helped a great deal. And so a lot of the original testing was actually paid from that, because we only really started billing government, I think it was last month or something. So for the other, you know, months, it really had been funding that came from Solidarity Fund. So we did access money from the Solidarity Fund. And also, you know, when I was talking about the academic laboratories that came on board for testing, they also were funded. They're actually currently funded by the Solidarity Fund to be able to do testing. So there is that funding available as well. So we really have managed to get, you know, a few millions of the billions.
Yeah. Story of our lives. Aren't we all trying to get a few millions of the billions? And I'll come to that story in a few minutes in terms of how the money has flowed. Prof, I think you've had a pretty impressive career in TB and HIV. You're nurturing young minds. You're doing a lot of important work. Mm-hmm. Going into COVID, what struck you the most in terms of taking a moment to reflect and look back and apply these decades of your leadership and your influence in the space to when COVID has arrived? What are some of the key lessons that you've reflected on during these few months of COVID, and any similarities between your work around TB and HIV when you've had those thoughts?
Yeah. I think one of the other key things about us South Africans, which always amazes me, is how we're able to come together during time of crisis. And one saw this, even with COVID as well, just as we saw it in HIV during the early days, and we saw this in that, like I was saying, even at testing level, it didn't matter whether you were private or public. We were all rallying around each other and saying, how best can we do this? And even when we had backlogs, the private sector was covering up and doing some of the, some of the work, for us. And so there's this resilience, with South Africans when we're faced with calamity, and we're able to come together. But also, what one has realized is that we need to be, and I think this is a lesson for the future, that because I'm sure COVID is not the last pandemic that we're seeing globally, there will be another one coming in. What we are now realizing is the reality and the scare of how a new pandemic can actually negatively affect gains that have been made on other, infectious diseases specifically. And I'm saying this because right now we are, 4 months, into COVID. And so when we're now looking at what about the other programs that we have in the country, and we're concerned with the fact that when we're looking at the TB program, it seems to actually have been negatively affected in that the TB testing numbers have gone down. And now we are trying to understand that. And it says to us, going into the future, whenever there's an epidemic that comes, we must always make sure that that epidemic doesn't take precedence and we then forget to look after other successful programs. And I mean, we had been saying this, but we really didn't think it was going to be this much. But I think now we're waking up to realizing that actually we need to strengthen, especially for some reason, it's just been the TB program, because we don't see a big difference in the viral load testing and HIV management program. So we're still trying to understand what could be causing that. So for me, it's saying when we make gains, we've got to try whatever it's going to take to make sure we sustain those, irrespective of what other calamity we face. And we need to actually learn and find lessons how to do that. And we're still trying to analyze the TB, scenario.
Yeah. Thanks for that, Prof. Prof, I think we're reaching close to the end of our call. So I think in closing, I would just like to ask you, what would your call be to civil society? So on this call, there's representatives of the Vaccine Advocacy Resource Group that advocates for accountable vaccine research and community-owned vaccine research, a range of organizations, over 131,000 organizations represented on this call today. What would be your call in the specific context of the NHLS, which has been pretty distant in terms of community advocacy and mobilization? We kind of view it as, that's the lab work. And I think a lot of us, a closest point of reference is the traumatic story of forensic services and lab services when it comes to testing around samples on rape and sexual assault. So interaction with the services has been minimal. What would you say is a key low-hanging strategic opportunity for us as advocates in civil society to engage with your work and support your work, especially as it relates to getting communities mobilized and aware?
Mm-hmm. Yeah, I think that's probably something that we still need to work at. And I think lately, actually, I'm now talking pathology generally, we are awakening to a reality that actually the public doesn't understand pathology services at all. I mean, and maybe even before we can, reach out to civil society and find, common ways of working together, we need to establish ourselves and actually appreciate the difference we make in health generally. And I don't think we have articulated that very well. As a result, I mean, like you say, people don't really understand. I mean, even now, if I were to ask, a few members, who are sitting here, what is their full understanding of NHLS? Last night, somebody was asking, what is NHLS on Facebook? What does it do? And how does it relate, to hospital services? So I really think we maybe as a field, we have not marketed ourselves, effectively. And that's the first thing we need to do. Because really, when you look at it, I always say, and this is me now, a mother saying to my children when they ask, what do you actually do? You don't have a stethoscope, but you say you're a doctor. Are you a real doctor? They used to ask me this ever so often. But what I tell them is, we actually, as diagnostics, we're actually the brains behind the doctors. Because there's no way you can make a diagnosis without, laboratory services. And so we are very key, and we need to make that known and get people to appreciate that. And probably we would then need to see how we can interact and engage with civil society in highlighting that. I mean, for instance, we're talking about TB testing. I know there's a lot of advocacy around TB testing, and we should be rallying around. Now that I'm saying there seems to have been a decline, how then do we get civil society to assist us, to actually make communities aware that it's important to continue, with your TB treatment as well as TB testing, and we don't forget that because of the pandemic. And secondly, as far as vaccines are concerned, I mean, Snazo will tell you, I've worked in HIV vaccines as well, and I think for me, we do need to find a vaccine for SARS-CoV-2. And so it's important for people to actually participate in these trials so that we can come up, as South Africans, if we can really make sure that we participate so that we can have an answer that talks to our country, and in a trial that has actually had enough participants for the country, so that the analysis of the data, actually we've got enough data that comes from the country, because then whatever decisions and whatever outcomes that come off, we will have a lot more confidence in those, and that they would be applicable to our to where we are. So I would encourage advocacy around vaccines. And then the other big area, especially because now we've come to level 2, is going to be how civil society can assist with us and everybody else within health in preaching these non-pharmaceutical interventions, because that's the only thing that we have so far for prevention of infections. So people, the message of social distancing, the message of masks, the message of hand washing and sanitization. So it really still needs to go. The fact that we have moved to a level lower, it does not mean we are over the woods yet. And we really don't want to make sure that we can keep the transmission, in check before, we get another surge, which we find that we cannot handle. So really, it would be for me to say to civil society, let's continue to get, communities, understand why it's important to make sure that these interventions are stuck to and adhered to. Thank you.
Prof, we're reaching the top of the hour. I think it's just left for me to thank you so much for your time and for taking time out of your very busy schedule and speaking with us today. It's been really insightful. I can just tell by the comments it's been quite an interesting, robust thought process that you've triggered. We'll certainly be in touch with yourself and your team to work on the post-call survey, which will also touch on some of the questions we've been unable to get to today. So on that note, we would thank you again. Colleagues, we will say goodbye to Prof. Mlisana as we get into our debriefing session once that is done. So thank you again, Prof. Have a good Thursday. Thank you for your leadership and your guidance, and we look forward to this being the first of many engagements.
Thank you very much. I truly appreciate it as well. Thanks. Bye.
So colleagues, we've said goodbye to Prof. Mlisana, and we can say goodbye to the rest of our guests who have joined us. We'd just like to take a roll call to see if, and you can unmute yourself, or could you raise your hand if We want to ensure that all of the partners are on the call. Is there a representative from the COVID-19 Community Constituency COVID-19 Front on the call? If you could make yourself known via the chat box. Is there someone here from the COVID-19, the Community Constituency COVID-19 Front? I can see VAG is here, APHA is here. I think in the absence of the community constituency, we will get in touch with all of you individually and reschedule our debriefing call for today. But on that note, colleagues, thank you for your inputs and your questions on the chat. We will send out announcements as usual on our social media pages around next week's call, and we will be in touch with individual partners to reschedule a engagement on the webinar debriefing sessions that we have planned. So on behalf of the VAG, the African Alliance, APHA, TAC, the Community Constituency COVID-19 Front, thank you for joining us and have a good Thursday.